Good afternoon, ladies and gentlemen. I'm Rick Rangelbraun with Toronto Paramedic Services, and on behalf of Chief Gordon McEachen and all the men and women of Toronto Paramedic Services, I would like to welcome Dr. Hoskins, Dr. Williams, Dr. Hewer, Dr. Schwartz, and all of you to Toronto Paramedic Services 45 station for this very important announcement. I'd like to immediately introduce Dr. Hoskins to come forward.
Well, good afternoon, everyone, and thank you, Rick, for hosting us here today at EMS Station 45. I want to start actually by thanking Rick and his team here at Toronto EMS Station 45 for generously hosting us here today. We all know as frontline workers, EMS workers, paramedics, are all too familiar with the opioid crisis that's facing our communities. And I want to thank them for their bravery and their tireless efforts in saving lives every single day. Ladies and gentlemen, I've asked you all to be here today to talk about a pressing issue that our government and our leaders in healthcare have been working hard to address: the rise in opioid use disorder and the associated opioid overdoses in the province of Ontario. And it's an issue, of course, that is of grave concern to all of us. As many of you may know, opioid overdoses have grown to become the third leading cause of accidental death in this province. And last year, our government made a commitment to the people of Ontario that we were going to tackle this issue head-on, in collaboration with our many partners across the province. And since that time, we've been working diligently to implement Ontario's first ever opioid strategy. I also want to applaud members of the media some of whom are here today, who have been actively working to raise public awareness of the opioid crisis. We appreciate your efforts and assistance as we work to get information to the public that will literally help to save lives. So the ability to share accurate information is critical to curb incidents of opioid use disorder and associated overdose. So that's why one of the key elements of Ontario's comprehensive opioid strategy is our commitment to enhance data collection. Gathering data is an essential component to building comprehensive, targeting, and effective public policy. So I'm here today to announce the launch of, and we'll shortly be seeing a demonstration of, the new interactive opioid tracker, a new public-facing opioid data tool that is helping government, local health care leaders, and frontline workers in our fight against the opioid crisis. The interactive opioid tracker is a web-based tool that allows users to view data from over 10 years on opioid-related emergency department visits, hospitalizations, and deaths in Ontario. And we now have mortality data to the end of June 2016 and emergency room visits to the end of September 2016. The updated data tells us that 412 people lost their lives as a result of opioid overdose in the first 6 months of 2016. And those 412 deaths compares with 371 deaths during that same 6-month period from January to June of 2015. This represents an 11% increase in overdose deaths. And these statistics further exemplify why taking action on this issue is critically important. But it's also important to point out that while we saw an 11% increase year over year, and this is of great concern, British Columbia saw an 80% increase in opioid deaths from 2015 to 2016. And Alberta saw a 40% increase in fentanyl deaths from 2015 to 2016. Here in Ontario, we have yet to see a similar spike. Although, as I mentioned, the numbers are definitely increasing and are definitely alarming. Even one death due to opioids is one death too many. The data in the tool provides the highest quality information available and can be used to assess long-term trends in opioid-related morbidity and mortality and support, logically, the development and evaluation of targeted policies and interventions that will further strengthen our response on a provincial and local level. And I want to extend my sincere thanks to Dr. David Williams, the Ontario's first provincial overdose coordinator, who is with us today and we'll shortly be hearing from. I want to thank him for his leadership and others in developing this tool. Because I know he had a lot of support from Public Health Ontario, who has joined us today, from the Provincial Surveillance Executive Steering Committee, and of critical importance, from the Office of the Chief Coroner of Ontario. So thank you all for your efforts to make this possible. Our government is continuing to work with all of our partners across the province to continue strengthening our response to this crisis. And as part of this effort, I am convening a meeting with mayors from across the province on June the 12th. This meeting will be an important opportunity to hear local perspectives and experiences and allow us to look how we can continue to work together to strengthen our efforts moving forward. So there's a lot of work still to be done, but our government and our partners have made significant progress since we first laid out Ontario's comprehensive opioid strategy last fall. We have expanded the fentanyl patch for patch program province-wide. In January, we delisted high-strength opioids, those that are most likely to lead to overdose. We're developing 3 new quality standards focused on appropriate prescribing for both chronic and acute pain and for the treatment of opioid use disorder itself. In the meantime, I've written a letter to the colleges that regulate our physicians, nurses, and dentists, asking them to ensure their members are incorporating the most recent national guidelines and best practices on opioid prescribing into their practices. This will help reduce the number of new opioid dependencies from forming. Ontario is also committed to supporting and expanding proven harm reduction initiatives, including funding for supervised injection sites here in Toronto and in Ottawa. And ladies and gentlemen, more than 30,000 naloxone kits have been distributed through more than 1,000 pharmacies in 200 communities across the province. And every provincial corrections facility is now distributing naloxone to at-risk inmates upon their release. We've increased the number and funding to pain clinics across the province, and we're increasing the mental health resources available to provide the necessary support. So, ladies and gentlemen, we are leaving no stone unturned when it comes to our efforts to addressing the opioid crisis that is gripping our province and the nation. And with tools like the interactive opioid tracker unveiled here today, we're going to be even better equipped to continue combating this issue. As I said earlier in my remarks, every new addiction, every life lost is one too many. Thank you very much. Thank you.
Thank you, Minister Hoskins. I'd now like to introduce Dr. David Williams, Chief Medical Officer of Health and the Provincial Overdose Coordinator. Sir.
Thank you very much, and great to be here today at this center here, and thank you, Minister, for your leadership and understanding the vital role that data plays in tackling issues such as opioid addiction and overdoses. As the Minister mentioned, I had been added the extra duty, besides the Chief Medical Officer of the Province of Ontario, to also being the first appointed Ontario Provincial Overdose Coordinator. We weren't too sure all what that meant and what all it's going to be, but it's an expanding role and it's been a challenging one. One of the things I did when I undertook the role back in the summer of 2016 was to understand, when I've been here doing SARS before, how important data was. Right from the get-go, the quality of data, how to obtain that data, and how to communicate that out to the public. And so we sat down right off the bat to look at the issues around our data related to opioid overdoses. One of the first things I did was to bring in experts. So I established a surveillance executive steering committee. One of the members of who is our chief coroner, Dr. Dirk Heyer, who's here today, and other key members around the table, including those from various parts of the ministry that do data collection, various experts from PI Public Health Ontario, and also individuals in clinical pharmacology and other ones that could assess and say, with our current data systems, which are there for case management, how do we take these and upgrade those and use them for surveillance purposes? They're not one and the same, but they're important things to be understood and to take part in. And so as a result of that, we also extended our time here. Dr. Heyer and Dr. Schwartz are here to assist me. They're on my committee in that regard. And so I'd like to thank Public Health for their assistance, because one of the things is to check our databases, look at the quality of those databases, and put them in a way that's presentable and that can be utilized by many stakeholders and individuals around the province as they deal with this problem, as the minister said, is one that we want to wrestle to the ground, and we've taken it seriously. I was pleased when we had the issue announced that in the summer and fall, both Minister Dr. Hoskins and our Deputy Dr. Bell understood the gravity of the situation and took it seriously with the announcement of the Ontario Health, with the strategy to go forward. Not a small task, a comprehensive one that I'm really proud to be taking part in. But more to the data today, what we're trying to do, we wanted to put together a method that could be utilized and could be handled by many different people. It's an interactive tool, and that you can search and look through and see the data over time. To know what happened yesterday is only in the context of what happened last week and last month and the year before in your respective jurisdictions. It has to be routinely updated, and we plan to do so once we're satisfied with the quality of the data, to make sure that when we're quoting it, we're confident that what we're saying is what is there. And we want to make it locally relevant in a way that you can translate that. Some have a sense, as you'll see from the data and as you look through it, and you'll have the opportunity to do so when we give you the information of how to locate it on the web page of PHO, that you will be able to look at that and see in local areas. One conclusion, people think that opioid overdoses is a Toronto issue only. There is no jurisdiction, no area in the province that does not have a problem with this. And that's one of the things of getting it out there, so you can see that in your respective jurisdictions, what's in our area, what does it mean for us? We want that top data right there. It will help you in that area there with many people and using many different approaches as our strategy is laying out to work this issue down. As I said in our when we did the conference in Ottawa that Mr. Hoskins and Mr. Philpott co-hosted, we did not get an Ontario situation yesterday. It's been accruing over well over a decade. And our deaths over year, as Dr. Heyer will note, have been increasing by 6.5% to 7.5% year over year. And we continue to see that increase over the time. It'll help us to increase the awareness of our public who have engaged and embraced the issue. And we want to make sure that they, including with members of the media here today, continue to do so. And guide our policy decisions, already informing that, and we're taking action on that, and evaluate population level decisions and interventions. What does the data tell us? Well, as I mentioned already before, our issue in Ontario is not like BC, where over in a very short period, it went up very rapidly with unique situations in there. And when I was aware of this back in early 2016, we looked at our situation and asked, do we have that same situation here or not? We knew that our numbers were already before that bigger than BC, but we have been accruing that over a long period of time, and we were waiting to see if we had any sudden rising. As Dr. Hoskins said, we have not experienced that, have not seen that like BC and Alberta has seen. So we want to look at the tool that way. We also want to look at, there are a number of different facets and aspects to this issue. It's not a single topic. It's multifaceted. There's many components and many different areas that need to be addressed in it. So our comprehensive strategy, I'm proud to say, has many of those aspects in there. And we're excited to see when that is going to be rolled out in the future. And certainly give credit to Minister Hoskins and to our deputy for bringing that issue forward and moving in a very comprehensive way on this complicated issue. It also means that we have to take an issue that has accrued over a decade in Ontario with our systems and that, and I can't see it going away suddenly overnight. It's going to take a while to get it back down again. We have to engage many stakeholders, many groups in different ways, and one of the best ways to do that is to give them the correct data that they can depend upon, they can trust on, because they don't want to hear that it was something yesterday, something new today, and something new tomorrow. We lose trust and confidence in our public. So we want to take the time with our committee to make sure our data is correct and useful, and we can stand by. We'll be showing a demonstration of that at the end. And so I'm going to save some comments for that later when we go and demonstrate the interactive tool, or the tracker, as Minister Hoskins has called it, on that time. But in a way, it's our chance to step out now and start to tackle this in another further way. We've already taken some initiatives that the minister's already noted, and we're looking forward to engaging with you, the public, with our stakeholders, our key people, everyone in the province. As the minister said, even one death is not acceptable. It is preventable, and we need everybody engaged on this one and staying on. Our best way to do that is give you the data you need to track that and understand where it is in your jurisdiction and what you can understand in your own area. So thank you for being here today. I'll be back up in a moment to talk about the tracking tool. Back over to you, Chief.
Thank you, Dr. Williams. I'd now like to ask Dr. Dirk Heyer, Chief Coroner for Ontario, to come forward and say a few words.
Thanks, Rick. So whenever I come to the podium, it always means that something tragic's happened. Nobody ever wants to see me. I don't take it personally, but it really is a situation that we're all trying to avoid. And at the Office of the Chief Coroner, we recognize the tragedies that occur, especially with preventable deaths, as Dr. Williams just pointed out and as Dr. Hoskins has earlier commented upon. Opioid deaths we have observed over the past number of years, unfortunately, a continued increase. It's been relatively steady, and it's continued to go up. But I really want to highlight, importantly, the number of young people that die. This is a tragedy that affects many, many young people, with an understanding that between the age of 35 to 44, it is one of the most significant contributors to death. And if you imagine the life expectancy that we now have in our province, the number of life years that are lost. All of these are preventable, and all of us should be working to strive to eliminate this problem. The other important thing I want to mention and to recognize is this crosses all socioeconomic groups. This isn't isolated to one area. This is not a marginalized section of society. This crosses all over. We were talking with our paramedic colleagues upstairs who provide service in this area, which covers a variety of socioeconomic areas in the area that they serve, and they're seeing it at all different levels. So important to remember those things. At the Office of the Chief Coroner, not only are we trying to answer questions about why somebody dies, but we also want to help to work to make recommendations, try to prevent future deaths. And this is an example of working together with our colleagues in the Ministry of Health and Long-Term Care and our colleagues in the Public Health Ontario office or area, as well as others on the committee, where we bring our data to the table and we bring our information to the table, and we work together in a collaborative way to develop ways to work to solve this problem. And the tracker is an example of this. We now will have a better understanding of what's going on in a reviewable, reliable, and sustainable way. And this is very important to be able to judge the trends that might occur over time and look at the interventions, because if we intervene, we need to know were those effective or not. And this is a way to do that. It's also important, and it's been touched on, to remember that we are only, unfortunately, a small representation of the problem. Deaths are by far the minority compared to illness, which is morbidity, and at least 4 to 1. So every death, 4 people are suffering significant challenges in their health with that use, and the number of people that use opioids is even far greater. The numbers are hard to identify and recognize, but they certainly are not uncommon. So with the tracker, we'll be able to see what occurs over time and be able to inform the strategies, as I mentioned earlier. The other thing that we can do with the tracker, and I think it will be shown a little bit, but not in great detail, is we'll be able to isolate down into local areas, as Dr. Williams was talking about. So what happened in Toronto, what happened in Perth, what happened in different areas of the province, so that people have the perspective of understanding how to intervene locally as well as provincially under the broader framework and the broader strategy. Finally, our office has been focus of media attention. We've been compared with other provinces about where's our data, why do you take so long to get the data, why haven't you provided us the data? And the reality is we want to provide the highest quality data, and we want to provide it in the most detailed way that we can. We have had some challenges in our approach investigatively, but our office has taken that challenge on, and we have introduced, as of May 1st, a new method that proactively is identifying opioid-related deaths and collecting data to be able to have a defined data set available in a much more timely way that will be going onto the tracker in a much more timely method than our current data, which is now, as you know, till the end of June 2016. So we're working on that, but not only will the data be quicker, but we also will have the ability to do greater analysis. So if you asked, is that an illicit? What percentage were illicit? What percentage were accidental? What percent were intentional toxicity? We'll be able to answer all of those questions in a much more effective way. So I'm going to not hold back the demonstration because it's going to be a very interesting presentation. I think we're all going to be available for questions after as well. Thank you very much for the invitation. Thank you, Rick, for chairing.
And thank you, Dr. Heyer. I'd now like to ask Minister Hoskins and Dr. Brian Schwartz to come forward, please. We're going to actually have a demonstration of the tracker here in front.
You may notice the difference. It's not Minister Hoskins here at the moment. But, we're going to show, Brian's going to take us through a demonstration here, and this is surveillance data, and we often talk about timeliness and other data coming forward. And one of the things we've talked about at our surveillance committee is between surveillance data and early warning systems. And certainly some of the aspects you've tried to address there is how we can get data more quickly, more rapidly. As you are aware, you may be aware that Minister Hoskins and I did send a letter out asking our emergency departments to increase the timeliness of their data coming forward so we can look at that and assure ourselves the quality of that and get it as soon as possible. As well as we have other committees that we put together to look at responding to the issue of concerning to the public around some of these illicit synthetic opioids that have drawn much attention from British Columbia. And we have a special committee on there which has EMS staff on it, 3 members, as well as police and other experts to deal with that system. It's a different issue, and we'll talk about that at another time. So right now we're going to look at the tracker here, and as Dr. Schwartz is showing you here, this is the Ontario-wide data. And you can see that there's 3 lines. If you can't see it from the back, there is ED visits in the blue, hospitalizations in the yellow, and the bottom turquoise is the death data. Always going right back to 2003 up till 2016. As we said, we have the coronial data for the first 6 months of 2016. We're waiting for the last quarter data of hospitalizations and ED visits, which should be coming in shortly, and we'll update the site whenever we get new quality data added into it. As you can see, by hovering over different things, you can actually see case counts, you can actually see rates based on populations over each of those years, so it allows you to look at different points in that. You can also eliminate, as Dr. Schwartz will show you, and you just want to look at hospitalizations alone, for example, or death alone, or ED visits alone, if you want to. So you have rates, and you have actual case counts. And we notice on the next slide here, we have expanded with some more data up until September 2016 with the ED and hospitalization. We hope to have all of 2016 on there for morbidity and mortality very shortly, and we'll update that as soon as we have it. Also, you can see here, if you look at the trends, you can shift to months and shrink it and enlarge it. so you can look at trends and directions. Some things may change quickly in a month, but that doesn't tell you really what's happening. You want to see what's happening over a period of time. You need to look at both those components to understand what is actually happening at that moment. So you can see when you shrink and enlarge, you'll see that. If you want to see the 2016 mortality data, you'll have to go to the monthly one, as we don't have the full year on that. So if you're looking for it, when you get the site, you can refer to that. Next slide. One of the things we wanted to do especially is that we wanted to have that every health unit in the province, we've divided it up so that it's by health unit and by LHINs, and so that they can look at it and understand what's happening in the respective jurisdictions. This also means we have a dynamic possibility of having our medical officers of health sit down with their LHIN counterparts and talk about what is going on in their area, how do we interpret that, what kind of things can we take from the overall strategy, and make regional or local to our perspective and make the impact, and talk to our local people about the local issues. And so they can go down and track all those ones, both by counts and by rates on that one. Also, not take up too much time, you can break it down by age and sex. And you see here by the graphs, there's the ages there, and then we can actually split by sex on there, and you see the difference with male, female during the time, and you can go back with different periods. And finally, we have where we have the drugs. Get it up there. And we track down the drugs that have been major ones that in the coronial system as cause of death have been contributors. Some are some individuals have 2 or 3 or 4 drugs on board, but they're deemed to be as part of it. It's not actually attribution per se. So if you add up those totals, you'll come up to more. And you'll see that it goes back and you can move it and look at different drugs. If you look at fentanyl, for example, in the turquoise blue, you can see we did have deaths of fentanyl way back in 2003. It is not a new drug in Ontario. When I trained way back, I don't go far back, one of my main drugs as a GP anesthetist was fentanyl. So it's not a new drug. And you can see the different ones in here, and now we're adding with a toxicological screening that Dr. Heyer talked about, and 2 or 3 of our other centers, we can track some of the new illicit ones that you hear about, such as furanol fentanyl and carfentanil, and get a better idea. Again, you can go by rates and cases and numbers on there, and you go by years, and we'll update that as the information comes forward. You can see that there's shifts in time of different choices of drugs. You can actually see that even up till now, the number of deaths due to fentanyl is still less than we used to have with OxyContin in the past. So it puts things into perspective what we're dealing with here. And as Minister Hoskins pointed out, with the different situation that what BC and Alberta are facing, and we learn from them what they're doing in their situation. We keep watching for that. We would certainly alert when we saw that situation occurring. But we have this other problem that's been occurring for well over a decade and building up on there, and you can see it's multifaceted, and we have a number of issues to deal with that our strategy that we're planning and rolling out will seek to address. So that's the demonstration of the model. You can access that. We'll give the information to you, and you can look at those different points throughout that time. As I said, we will be updating the data through PHO when we have it and are assured of the quality of that data. We'll incorporate that into the interactive website, or the tracker as we're calling it. So that's the demonstration. For that, I'm going to open it up for questions with Mr. Hoskins. Who's there?
Thank you, Dr. Williams and Dr. Schwartz. So now we're going to open up the floor for any questions for Minister Hoskins or the gentleman here.
Get it up to date with current data.
Sorry.
How long do you expect to get it up to date with current data?
So from the death data, we are working as hard as we can. The current data management process that we have right now has caused us challenges, and that's why data has been not as quickly coming. And we're employing a variety of strategies. So within the coming months, we're going to hopefully have the end of 2016. Our new tool started May 1st, 2017, which allows us prospectively or at the start of the death. So we're hoping to have that. Our goal is to have that data available within 3 months. So from May, June, July, we should be getting that 3 months reported the 3 months after that. So again, quarterly, but now much more timely, within 6 months of the death. We're hoping to have that up on the tracker.
For mortality and morbidity.
So the morbidity I can't comment upon.
As I mentioned, the minister and I'd sent a letter to the emergency departments. Their hospitalization ED data used to be sometimes up to 6 months out. We've asked them to move up on that to get it to at least within a month. We're trying to get down to weekly reporting. So that's a new shift. We're going to wait and as that comes in to see what the quality and make sure it's thorough and it's complete in the data before we attempt to put it out in any reports on that. So that's another step we're taking forward that started in the beginning of April.
Some public health authorities have called for the ways of real-time data so they can see if an wave of overdose cases is currently happening in their area. Is that something that's ever going to be helpful to police?
I think the point about real-time data is understanding what it is and what it can be used for. What we talk about in our early warning system, I think what our public health units will ask them to do back in the fall is to set up a qualitative surveillance method. That's where the public health units combined with the emergency departments, EMS, police and fire, and their needle exchange and street nursing staff, when they hear of something unusual happening, because we're talking about the early warning mostly related to the public's perception or concern around these highly toxic illicit synthetic opioids that you hear out in BC. I mentioned a couple examples with carfentanil and phenylphenol, and there seems to be new ones coming all the time, because if we want to know that, we want to be able to say, what are you going to do when you know that, and what kind of response can we undertake that might prevent people from consuming those drugs, because they tend to be street drugs, recreational drugs, whatever. And our message has always been street drugs and recreational drugs is never good news. And especially with this kind of thing coming out with contaminants, you really have to take them as highly hazardous and be extra, it just is not a good idea. But if we can find out information on our early warning, the real-time system, then we're trying to build that now through our other committee, which has a long acronym, ISOPRAC, which is the Illicit Synthetic Opioid Prevention Response Advisory Committee. We've been meeting now for 4 or 5 months looking at different issues, including the data systems and the alert systems we need to pick up these other ones that could be clustering all of a sudden in an area, much like you saw in British Columbia, where you hear reports of with rec drugs going out in a certain area, so we can respond quickly to those. We have not seen those events yet, fortunately, but we're not taking it lying down. We want to move on it and be prepared if it does occur.
After this general treatment prevention, will this or something like this be available to the general public down the line? This is very sort of, for the insiders. What about for the public?
So this will be a public-facing website available to the public. And I think, that's a useful question. I think partly we rely on the media, I think, to, excuse me, to sort of do the heavy lifting and the hard work to interpret what's on the website and interpret it in a way for the public to be able to easily digest. But I think it also begs the question of opportunities that we have as well to, notwithstanding the transparency and the fact that this is a publicly available website as of immediately, there is an added responsibility of all partners, really, is to use this data for public advocacy and education so that individuals, and that's the beauty of it also being broken down to the level of the public health unit and to the LHINs as well, is that that all our health partners and our political leadership will have the opportunity to speak definitively and with confidence about the situation that's occurring in their local community.
The most, what's your expectation? Paramedics or?
We've already given it out to our medical officers of health and our LHIN leaders, and they'll be looking at it from their planning standpoint. Other stakeholders such as ED departments, sometimes physicians will want to see what's going on. Many different stakeholders have been asking for some information on this, and they are very interested in seeing the trend analysis because they don't see it as a one event. They see something that's been accruing over time, and they want to be able to look at it in that perspective rather than just seeing, well, we know what the data was last month, but how does that compare to the last 6 months, the last year, the last 5 years? And it puts things in the right perspective for them and how they do their planning, strategy, and education of their public, to engage the public, and to engage the physician community. Because our opioid addiction issue, as Dr. Heyer has noted, is not just a back alley overdose issue, it's pervasive. And there's many people, family, have relatives and friends. There may be friends in your office that could be addicted. We're not talking about a simple thing, and we want our public aware and engaged in this because it is a full charge ahead to try and bring this one to the ground?
There are plenty of experts that say that this is being caused by illegal drugs more than the legal ones. These drugs usually come, as experts say, from China through the mail or through ports. Is anything being done with the federal government regarding these legal drugs?
Yes, and certainly there is a role to be played by the federal government, and they are playing that both with regards to, they've introduced legislation to ban the importation of pill presses, for example. Also in terms of border services now, where I don't know if it's passed or if it's introduced as legislation at this point, where they did not have the ability, for example, to, at borders, to open envelopes below, I think it's 60 grams. So there was the ability, and it was exploited obviously, for individuals to import small quantities in a manner that border authorities were unable to, did not have the legal ability to investigate at that point of entry. So there's I think, to get back to the beginning of your question, it certainly is a mix. There's no question that the practice that was introduced and promulgated by Purdue in the 1990s particularly, that I think erroneously gave confidence to prescribers, to healthcare providers, that for a myriad of reasons that opioids were an appropriate and safe approach to dealing with pain. There's no question that has dramatically impacted the number of Ontarians and Canadians that are that utilize opioids. We just saw recent data. Canada is the second highest per capita prescriber of opioids in the entire world. So that stream has significantly contributed to the situation that we're seeing, as well as what you've referred to, the illicit stream. And that speaks to why our efforts need to be comprehensive, with the federal government obviously involved in those areas that I mentioned and others, but also the work that Health Quality Ontario, for example, is doing on developing best practices and quality standards for appropriate prescribing, the recent national guidelines on opioid prescribing for non-cancer, chronic pain, those sorts of measures are equally important to hopefully avoid people from going on opioids in the first place. And then I also want, if you'll allow me, I want to really commend Dirk for the exceptional work that he's done over recent months, sort of taking up the challenge, if you will, and it's been an exceptional challenge of reimagining how the coroner's office investigates and makes determinations with regards to suspect opioid overdoses, fatalities, that other jurisdictions, I think we've seen. The data that came out recently, I think today or yesterday, from Alberta for the first quarter of this year, makes you wonder why we can't have this data in a more timely fashion. But you'll see from British Columbia and you'll see from Alberta that much of the data, recent data that comes forward expeditiously, are suspected cases, or they don't have the level of confidence that has been so important to the coroner's office. We don't want to put data out and then find ourselves a month later we're having to revise that number. We believe that it's important that we have confidence in the data that we're providing, and having that confidence combined with changes that the Office of the Coroner has made starting in May, we'll find ourselves in a situation later this year where the lag time for mortality data, but data that we can be confident in and don't have to constantly revise, that data will have about a 3-month lag time. And our ER data will be, we're asking our emergency departments or hospitals to provide that data on a weekly basis. They began doing that in April. We're now testing and confirming the reliability of that data, making sure that the health workers that are providing that data are appropriately coding and appropriately educated. But again, in the not very distant future, we're going to have confidence in data that we'll be making available probably for the most part on a weekly or a bi-weekly basis on visits to emergency rooms. So I think we're going to see in a very short period of time data which is not only more timely, but also data which meets that test, which I think, particularly trained as a statistician and epidemiologist, having confidence in the reliability of that data is extremely important as well.
More funding for
Can I go there and then I'll come back to you? Sorry.
For the city of Toronto is asking for money for public health officers to deal with the opioid crisis.
Yes.
Any decision on if that's going to be happening, more funding for 3 more?
So I know that my ministry, as well as the city, is having conversations. I myself spoke last week to Joe Cressy, who's the councillor most, I think, certainly engaged on this issue as well, with regards to the opioid crisis. So we spoke at length with regards to that, as well as the safe injection services. I know that in the first instance, the Board of Health had made the application to the city for the funding for these 3 positions, and that funding was denied by the city. Subsequently, at the end of March, March the 30th, we at the province received a request to fund those positions after it was denied by the city. And it's been 7 or 8 weeks where we're doing our due diligence, working with the city, but I'm confident that we'll be making a decision in the very near future on that.
So what were the mechanics of the chief coroner's office that were angry you in releasing the company that was, I might have just a couple of episodes, but I never thought what it was angry.
So the challenge was that we weren't able to identify an opioid-related death till the death investigation was complete. So that required the coroner and the police would do the initial investigation. There'd be an autopsy examination, toxicology would be completed, and all of that takes a fair period of time. And the mechanics that we had in place, to use your terminology, was that we wouldn't identify that till everything was complete. So what I've done, or we've done, not I, we've flipped it on its head. So in fact, what we're doing is when we have a suspected drug-related death, we're engaging early on, right at the start, and collecting data. We may collect data in too many cases, but that's okay because we'll then exactly evolve as we do the toxicology and the additional testing. So we've also then asked that opioid-related deaths and drug-related deaths be made a priority. So the Center of Forensic Science has stepped up and they're going to do their testing a little bit faster. The pathologists, forensic pathologists who are doing the autopsies are going to complete those cases as a priority. And we have a mechanism to be able to collect that data and to monitor those cases throughout. So we've done all of those different steps.
So is it toxicology tests that make it upstream in terms of the sequence of events, or what is it exactly?
Sorry, what's...
In terms of the sequence of events that you guys undertake, is it the toxicology testing that makes it higher up the list?
No, everything together. So from the scene through to the pathology, through to the toxicology, everything is moving it up. So everybody has stepped up together. And back to your question, the data will have a better understanding what's illicit and what's not illicit, because that's crucial. And so being able to answer that question, this is the type of information that we're going to be able to answer much more quickly and much more effectively. But again, it was everybody stepping up, and it's everybody working together, again, recognizing the significance of this public health problem.
That was my next question. Do we have any idea of the percentage illicit versus legal?
No, we don't have a great answer for that question right now, and that's what we're focusing. But in the new, since May 1st, the way we're collecting, I'm now really going to be on the hook for this, but since May 1st, we've been collecting exactly information to answer that question in an effective way. The importance that we have to also do is if we have a defined data set per case, then we can compare all of the cases. Similar to what we're talking about on the tracker, if every case has the same data collected, we can then aggregate, and then we can look, and then we can do comparisons, is exactly the question you're asking.
Minister, on a separate matter, the Changing Workplaces Review calls for the government to allow physicians to unionize, which they're currently barred from doing. Just a year ago, this government didn't want to talk binding arbitration. Now you've got an agreement with the OMA, and now you're talking about potentially even letting doctors unionize. Why has the government's thinking changed so quickly?
Well, I think with regards to, first of all, I'm pleased that we do have a tentative agreement with the OMA, subject to ratification from their memberships on the issue of binding arbitration, and anticipate over the course of the next month The membership will have an opportunity to vote on that, and hopefully we'll ratify it, so it gives us an opportunity to work towards a full agreement. With regards to the Changing Workplace Review, that is a report that was requested by the Minister of Labour, and so and it has, as you are aware, a large set of recommendations. I know that Kevin Flynn, the Minister of Labour, is currently looking at that independent advice. We have yet to state what the government's response to each of the recommendations, what our response will be, but certainly that's one recommendation.
Next week, and potentially letting doctors unionize would have a massive effect on the provincial health system, the single biggest budget item in the province's budget. This is a massive change.
So we won't have to wait long if, as you say, the legislation is being introduced, or the proposed legislation next week. But these are, I think there's 100 or even more than 100 recommendations, if I'm not incorrect, in the report. So the Minister of Labour and across government, we're obviously looking at and studying the various recommendations, and shortly we'll have a response with regards to each of those recommendations and what the government's position is.
Dr. Last question. Sorry to put you on the spot, so you can answer more on the data you're collecting about legal versus illegal drugs and opioid deaths. How soon do you think you'll be able to tell us, here's the vision up there?
So as we started the new process May 1st, and we're anticipating our goal is that we would have the final results from those cases within 3 months. So May 1st, if a death unfortunately occurred on May 1st, 3 months from then, we're expecting to have that final result. So if you take that grouping of 3 months, it would be another 3 months till we had that whole quarter of deaths. So 6 months from May 1st, I think I've got it calculated right, we would have a cohort of a quarter of the year, which would be it'd be a start. It wouldn't be reliable across the year, but it would certainly be data and would have those pieces of information available.
Could you speak to how that information might be useful for the province?
Well, I think it will be critically important. I also think it's important to recognize that often it's a mix, right? So Alberta, for example, have recently published data that looks at the proportion of deaths where there's documented evidence that the individual received opioids through a pharmacy, were prescribed and received within a 30-day period prior to the overdose occurring itself. And we know how high the per capita prescribing of opioids is in this province. So I don't think we can necessarily assume it's an either or. It may be that the trigger that led to the overdose itself and the fatality, it was triggered by legal or illegal, but often there's overlap in terms of an individual's experience or substance use disorder. But clearly, and this speaks, I think, to the earlier question about the federal role and the role of law enforcement and corrections, that as we're able to ascertain more clearly the role that licit and illicit play, and you'll see from the tracker that the drug involved isn't necessarily the only drug that was found in an individual system at the time of death. Often it can be a combination, but as we tease out the presence of licit or illicit and are able to source it, I think it gives us additional advice on how to intervene because the approaches can often be quite different, how to intervene to try to stem, I think, as you're alluding to, particularly the illicit.
Okay, thank you guys.
Thanks, everybody. Appreciate taking the time.
So thank you, Minister Hoskins, Dr. High, and Dr. Williams and Dr. Schwartz. Just over my corner in a moment, we'll have an opportunity for two Toronto paramedics, John and Sebastian, to show you the medications that we use to actually combat the opioid problem. It'll be just over in the corner. Thank you very much for coming. On behalf of Chief McEachen and Toronto Paramedic Services, have a wonderful day.